Welcome to the Sunday special on TopMedTalk. It's a potpourri of our favourite longer pieces, ideal for downloading and enjoying when you have a little bit more time. TopMedTalk.
I'm Desiree Chappell with TopMedTalk here at the Intensive Care Society State-of-the-Art Meeting 2018. I have the privilege to sit down with Jonathan Downham, who is the, official podcaster? Is that right, Jonathan? How would you introduce yourself?
I kind of got involved with the Intensive Care Society back in 2015 when Ganesh, the original organiser of the conference back then, asked me to be involved as part of the social media team. So originally I was just brought in to tweet, if you like.
Oh, okay.
But since then, I have my own podcast, and it was last year in Liverpool that I said, well, why don't we do some live streaming as well? So we're actually live streaming to Facebook, YouTube and Twitter the conversations we're having, and then I rip those sound files and produce them as podcasts as well. So I've kind of got 3 different hats on at the moment.
Yeah, that's super cool. So well, if you hear anything in the background, they're giving some speeches that we probably should be listening to, but I wanted to sit down and talk to you. So you have a 4th hat, though. So what is it that you do on a daily basis? Okay,
I'm what in this country is called an advanced critical care practitioner. So probably about 2011, there was a recognition in this country that with the change in the medical careers, there was going to be a gap starting to develop whereby the junior doctors were coming through intensive care and they were only staying there for sort of 3 to 4 months at a time. Obviously they come with very minimal skills. By the time they left they would have some skills, but then you would do the whole thing over and over and over again. So a bit like the US, we started to develop specialist nurses originally.
Yeah, so an advanced level degree.
Yeah, so we do. Most of us are trained to master's level now. We do a lot of the things that the junior doctors traditionally did. So we do all the technical stuff. We do the patient assessments, appraisals, delivering the care, prescribing the drugs, pretty much everything that they do. The only thing in this country we can't actually do unless the individual trust we work for is happy to recognise that is to actually intubate somebody with drugs. Oh. So if the patient is dead, if you like, if it's a cardiac arrest, we can intubate.
Gotcha.
If we need to give drugs to intubate, we have to do it with close consultant supervision.
Sure.
So that's what I do as a day job as well.
Do you put lines in, like central lines and A lines and things like that?
Central lines, A lines, dialysis lines. I've started putting things like chest tubes in as well. So that's what I do for my day job. And it was originally nurses who were moving into the role, but now we're getting paramedics doing it, physiotherapists doing it.
So are those bachelor prepared or? Yeah,
they've already, a lot of them, well not all of them necessarily are degree level, but they will be moved through in a modular way to what we call a postgraduate certificate, and then they move on to a master's level qualification.
And that do you think that the workforce decision, I mean, just because you needed to bring more people in. I mean, I know that having bedside nurses, I mean, there's a struggle to find enough people to do that. But so you kind of feel like you're poaching nurses whenever you're asking them to do an advanced degree. So do you think asking a paramedic or physician's assistants or something like that is a workforce issue, or is it just those people have a good place, fit well into that setting?
I think they very much fit well into it. I think the ones that they pick are the ones that are aspiring to, because when you hit the ceiling in nursing, I mean, I'm sure it's the same in the States, that you either go into education or you go into management, and there really wasn't much else to do after that.
Practical.
Now, people like me who want to continue at the bedside, there was never any other option other than to stay as the nurse in charge. But then when this opened up, then suddenly you've got somewhere else to be as well. You can still be at the bedside, you can extend and expand your skills, and probably some of the best practitioners are some of the ones that aren't nurses as well. The paramedics and the physios bring so many other things to the role, and as a consequence I think they're just helping to develop it as well. We're closely monitored now by the Faculty of Intensive Care Medicine over in this country, so we have to go through accreditation with them every 3 years. That has to be done with your lead consultant, so it is very closely watched. And hopefully the accreditation means that we are going to have a universalised, standardised training across the country. So It's a right step forward. I think probably with a lot of professions now in healthcare, we're all moving up into each other's roles. All those borders are merging together. And it's like somebody said that who's at the bedside now? I don't care if it's a doctor, a nurse, a paramedic or a porter who's delivering my care, as long as they're qualified to do so. I don't care what title they have. And that's the way that we are now.
Yeah, well, and still the model of that you're working as a multidisciplinary collaborative team, I think is really one of the most important things.
Yeah, absolutely.
And that you have people that can make an ultimate decision if they need to do that, the physician or, the consultant.
Yeah.
And then you're training others, these, doctors in training, that they can see this collaborative team approach.
Well, I think one of the worries from the junior doctors as well is that we are taking away their learning opportunities. But actually we're not, because what's happening now, once we have got those skills, we are now just another teaching resource for them. Actually we're improving their learning opportunities, because whereas before, say, the registrar was busy around the hospital, they wouldn't be able to supervise their juniors to do the things that and we can do that now. Yeah. So actually we're improving their opportunities. I've
worked with residents and physician residents before, and as a CRNA, nurse anesthetist. It was interesting because there were probably questions that they would ask me, but not necessarily ask the attending.
Yeah.
You know what I mean? You just have a different relationship, a different conversation. Sometimes it's not practical is not the right word, but just that you're able to work together and see a little bit more of what it's like in the trenches.
Yeah, absolutely. And I think probably working with somebody like you or me, there isn't the peer pressure that they feel with a doctor who's slightly higher in the rank.
What just comparing and contrasting what the UK is doing in the US. I know Monty and I have had this conversation, and when I've been over here in the UK, learning more about how the UK is dealing with workforce needs. And the fact that there aren't as many doctors, and utilizing nursing staff, utilizing paramedics or physiotherapists to integrate care and take care of people that as we have more people, the baby boomers coming through, and
there is a lot of
needs.
There is a lot of what the medical profession does that is fairly standardized anyway. You get a patient with a diagnosis and you will take them through this pathway, and you don't always need a doctor to deliver that.
Right.
What I think the doctors are there for is because they've had the medical training, they've had the physiology, the anatomy, the pharmacokinetics and ecology and all the rest of it. They're the ones who can pick apart the diagnosis and decide what direction they go in when it becomes difficult.
Yes.
Whereas somebody like me, I can see the more obvious stuff and I'm happy to treat that, but sometimes I need my medical colleagues to just say, I'm not sure, where are we going with this? And that's where their skills, their experience and their training comes in useful, really.
Yeah.
But, I can take your average sick patient in A&E and let's say it's a septic patient. I know it's a septic patient. I can treat them from coming through the door to being intubated and going to ITU, and I can do that independently and safely. What I can't necessarily do is get the patient with the unusual diagnosis.
Right.
That's when I need the medical team to help me out with their knowledge and skills.
Well, it's so interesting. Jonathan, thank you so much for sitting down with us. I really appreciate it. I love what you guys are doing and wanting to podcast and get more involved in social media.
Yeah.
We were talking to Hugh Montgomery earlier about how this meeting has developed, especially in the recent years.
Yeah.
And the fact that it sounds like to me that really getting involved with this social media effort and getting the younger people involved and wanting to change the meeting up a little bit, it's worked really well. It sounds like that you've helped facilitate
and
that.
It's interesting, isn't it? I was talking to somebody about this the other day, that whilst we are live streaming to places like Facebook, the generation of the 10, 12, 13-year-olds at the moment who are going to be doctors in 10 years' time aren't using Facebook.
No.
And we've got to keep up with that,
It's so true.
Absolutely. So we've got to start thinking about how we're going to branch out and communicate with the people of the future. And I think this kind of thing is how we're doing it. Yeah.
What I love about being able to sit down and have these conversations, it's a supplement to everything that's going on here, and it just, I think it just creates a lot of excitement and more curiosity to want to be able to come to meetings like this, to hear the presenters, to hear what some of the things are that are talked about. We have the opportunity to kind of dive a little bit deeper, or kind of go superficially and say, this is something that, you know, is valuable.
And how much networking are you doing now that you weren't doing before you started the podcasting thing, you know?
It's unbelievable.
Yeah.
The people that we've met, the conversations that I've had that I never, ever would have had before.
Yeah.
You know, with the diet, we just sat down with Denny Bear and talked to her about ICU nutrition, you know, as a dietitian, ICU nutrition. And I would never have had that conversation just going to a meeting like this. And now we're able to let people hear that.
Yeah.
So
and that's why, for me, something like Twitter is valuable, because once I started on Twitter, my network grew exponentially.
Yeah.
And Twitter, one of the values of Twitter for me is that the hierarchy, there is no hierarchy.
Right.
You can talk to everybody on an equal level. And normally, I would say, because a lot of the podcasts that I do, I get through to people from Twitter, and I'll say, that's interesting, can we talk about that on a podcast? And I would say 90% of them have said, yeah, love to.
Yeah, that's fantastic. Jonathan, tell us what your podcast is.
It's Critical Care Practitioner podcast.
Okay, and how do we find that?
It's in iTunes. It's in most of the podcast catchers these days, so just look for Critical Care Practitioner, and that's how you'll find it.
Great. And that's your handle on Twitter?
At CC Practitioner.
At CC Practitioner. Yeah. Great. Well, thank you so much for sitting down
Thank
with
you,
us.
Desiree.
It's fantastic.
It's been lovely.
Yeah. We've been neighbors the whole time, waving at each other, so I'm glad we were able to sit down and chat.
And we got the selfie as well.
We did get a selfie.
Okay.
Again, we're at Westminster Abbey. It's just right around.
That's just wonderful. The view we've got at the moment. It's a shame we can't share it, isn't it?
Oh, we've been sharing it. Don't worry. Lots of pictures on.
Oh, yeah, of course.
All right. Well, thank you guys so much for listening. Check back tomorrow. We'll be coming to you again from the Intensive Care Society State of the Art Meeting 2018. Thanks so much. Cheers.
Thanks for downloading and listening to TopMedTalk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the TopMedTalk website, topmedtalk.com. and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website edpom.org/meetings. Our next big event is EdPom USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. edpom.org/meetings.